Sarcoidosis. Sarcoidosis is an immune-mediated disorder. We do not know what causes this disease. It's a multi-system immune-mediated disorder that preferentially involves the lungs and is characterized histologically by a non-caseating granuloma virtually in any organ, especially in the lungs and chest lymph nodes. We think sarcoidosis is the consequence of a specific immune and inflammatory reaction to some unknown antigen. From the clinical point of view, it presents with hilar lymphadenopathy, pulmonary infiltration, ocular and skin lesions. Universal prevalence is 10-20 over 100,000, so it's not so rare, but African Americans are much more affected than the rest of the population. 2.4% lifetime risk as compared to 0.85% lifetime risk for whites. There is a risk aggregation in families and specific races, being 3-4 times more common in blacks. Pathogenesis. Environmental factors can be the cause of the disease, because there is a spatial and temporal clustering of races and a clustering of cases within the same community, pointing to an environmental cause of the disease. There are reports of work-related risks for healthcare workers, nurses, firefighters, and military personnel. A case control study of sarcoidosis cluster on the Isle of Man demonstrated that a greater percentage of cases than controls reported previous contact with a sarcoidosis patient, although many on the isle are inbred. The data points also to something environmental: exposure to industrial organic dust, occupations with building material and other, gardening supplies, and education trades are among the main risk factors for the disease. No single infective agent or antigen has been consistently linked to sarcoidosis. Hypothesis: mycobacteria viruses cause sarcoidosis, but so far no infectious agent evaluated has fulfilled the Koch's postulate. T-cell-mediated response and oligoclonal T-cells have been demonstrated in sarcoidosis, and there is an upregulated Th1 pattern of cytokine production showing enhanced immune reactivity. So, selected environmental and occupational exposures, positive associations with agricultural employment, insecticides at work, pesticides work, mold, mildew, musty odors. Negative associations with tobacco smoking, childcare or children, cat, animal dusts, feeder down, pillow stuffings. So, immunopathogenesis. The fundamental issue is the position and formation of granulomata in the different organs. Granulomas are an effective measure undertaken by the immune system to segregate the bug in the case it cannot destroy it. So, the roles of a granuloma are to confine pathogens and restrict inflammation. If you create a hugely inflammatory environment within the granuloma, it will be containing a lot of inflammatory pathogens, preventing them from spreading through the body and create a generalized inflammation. In this way, it also protects the tissues, even though it can also destroy them. This has been evidenced also in archaeological findings in Egypt, when it was tuberculosis granulomas with live pathogens inside were discovered in mummies, so there is a containing capacity of thousands of years. The main cell type involved is the macrophages, that can become single macrophages or fuse together and become giant multinucleated cells. So, macrophages gain a lot of secondary bactericidal capacity and exert this capacity towards the center of the granuloma and somehow lose their phagocytic capacity at the edges of the granuloma, where they become giant multinucleated cells. So, in the center they have a lot of activity, while in the periphery they lose some of their phagocytic capacity and they become giant multinucleated cells. Sarcoidosis, there is an unknown trigger, maybe a microbe, an environmental factor, mycobacteria, propionobacteria, that releases antigens for T cells. The antigen is then presented to the macrophages, and there is a huge production of interferon gamma and TNF alpha, and they start creating, via an adaptive immune response, the granuloma. The antigen is typically confined inside the granuloma, and if the antigen is destroyed at the end of the granuloma formation, then the granuloma will dissolve and you will have a normal remission. On the other hand, if the antigen is still there, granuloma may increase in size, and if the antigen is still spreading, you can have a new granuloma. In the latter case, you will have a chronic and fibrotic phase mediated by TGF beta. Since there is a significant in the latter chronic, the immune system starts the contra-regulatory measures like the activation of Treg cells, which are extremely involved in this disease. And you may have the so-called immunologic paradox. Since there is a huge involvement of Treg cells, these Tregs might be able to reduce the activity of cytotoxic T cells, and those patients will have a negative Mantoux test because they are anergic. So they have a huge Th1 response, but the general Th1 response is dampened by the excessive amounts of Treg produced that are trying to control the Th1 response in sarcoidosis. This happens with patients that have a huge granuloma. You test for TB and they show to be anergic. So you see etiologic triggers plus environmental effects, microbes like mycobacteria, propionobacteria, organic agents, inorganic agents, trigger antigens for an innate immune response, and genetic susceptibility plus host factors lead to this adaptive immune response triggered. TNF alpha, interferon gamma can lead to remission or become chronic and fibrotic. Clinical presentation. Presentation depends on the extent and severity of the organ involved. Approximately 5% of cases are asymptomatic and incidentally detected by chest X-ray. Most of the cases have a pulmonary presentation. The acute phase, we have fatigue, fever, arthralgia, dry cough, dyspnea. The subacute phase, low-grade fever, dry cough, dyspnea on exertion, erythema nodosum. Typical symptoms are fatigue, night sweats with loss. When you see a patient like that, you might also think about TB, HIV, lymphoma, and cancer, mostly hematological. There are two specific presentations for sarcoidosis. Lofgren syndrome in 35% of cases. We have fever, arthralgia, arthritis, the ankle, especially, males much more than in females, erythema nodosum, females much more than males, and hilar lymphadenopathy. This is quite common, 1 in 3 patients. Must bear in mind that if the patient has all the symptoms depicted here, you make the diagnosis of sarcoidosis without a biopsy. Consider that the biopsy in this case consists in opening the chest of the patient to biopsy the hilar lymph node. It's extremely typical to find bilateral ankle arthritis or arthralgia. If the patient is female, it is more common to have arthralgia than arthritis. Female patients also present with erythema nodosum. Hereford syndrome. We have the presence of fever, uveitis, conjunctivitis, and sialadenitis with or without facial nerve palsy, so Bell's palsy. This is rare but still very specific and indicative. If you have a patient presenting with this triad, you can make the diagnosis of acute sarcoidosis. Physical findings are pulmonary findings, dermatological manifestations, ocular manifestations, cardiac manifestations, neurologic manifestations, which are rare. Pulmonary involvement. Lung manifestation is the most common one in the disease. A staging system has been set up for this, and it is quite important because depending on the pulmonary stage you make a lot of consideration on the prognosis of the patient. Stage 1, we have bilateral hilar lymphadenopathy without infiltration. Lymph nodes are characterized inside by a number of coalescing granulomas on each and is staining preparation. So stage 1, bilateral hilar lymphadenopathy without infiltration. Stage 2, bilateral hilar lymphadenopathy with infiltration. We have a mixture of hilar lymphadenopathy and some reticular aspects on the periphery of the node. In stage 3, we have infiltration alone, so not lymphadenopathy. The mediastinum is free and you have just peripheral opacities in the lung parenchyma. In stage 4, we have fibrotic bands, bulle, hilar retraction, bronchiectasis, and diaphragmatic tenting. Extreme evidence of severe involvement of the lungs without hilar lymphadenopathy and with distortion of the lung parenchyma. There is a fibrotic involvement of the lung with bronchiectasis due to the fibrosis traction and widening the lung. Skin involvement, although not a life-threatening condition, it can be emotionally and physiologically devastating, psychologically devastating for the patient. The major manifestation is erythema nodosum, appearance of painless cutaneous nodes that are covered by badly inflamed skin that are painful. It appears in roughly 10% of patients. Remember that erythema nodosum is a hyperinflammatory response of sarcoidosis. So if you biopsy the patient there, you will find the panniculitis, inflammation of the subcutaneous adipose tissue, independently of the disease associated with erythema nodosum. Consider also that a number of diseases like vasculitis, Takayasu arteritis specifically, or diseases with a significant inflammatory response may be associated with erythema nodosum. It makes no sense to biopsy a patient there because you will not be able to discern the underlying disease. Lupus perni is the most specific associated cutaneous lesion, women more than males, associated with chronic diseases and extrapulmonary involvement. It is the localization of sarcoidosis in the nose. Purplish rash is often seen on the cheeks or nose. Maculopapular plaques are possible. As a finding specific for sarcoidosis is the predilection of skin involvement at the site of previous scars. The patient tells you he has a scar on his body that suddenly comes out becoming inflamed and red. Same thing happens with tattoos. All tattoos that get inflamed after sarcoidosis, probably the ink used for this tattoos is working as a foreign body for the cells that are responsible for sarcoidosis. They have also liver and spleen involvement, 10% of patients, elevated serum aminotransferase and alkaline phosphatase. Cholestatic syndrome characterized by pruritus and jaundice, hepatic failure or portal hypertension can develop. Detection: liver involvement is usually clinically silent. Detection of hepatic and splenic lesions on CT is described in 5 and 15% of patients. Portal hypertension with variceal bleeding, a hepatopulmonary syndrome with refractory hypoxemia, and cirrhosis leading to liver failure occur in only 1% of patients with sarcoidosis. We can have also neurological involvement in 10% of cases. We have 10% of patients. We have cranial nerve palsies, headache, ataxia, cognitive dysfunction, weakness, seizures. At CNF analysis, we have non-specific lymphocytic inflammation. We have measuring increased ACE levels, neither specific nor sensitive. Oligoclonal immunoglobulin blends in the CSF are elevated. Multiple sclerosis may be a differential diagnosis. A nuclear magnetic resonance may help you in finding small granulomas. Ophthalmologic complications involved in 25–80% of patients. Eye plus adnexa. Have anterior or posterior granulomatous uveitis, chronic anterior uveitis with insidious symptoms leading to glaucoma and vision loss is more common than acute anterior uveitis. Conjunctival lesions and scleral plaques. Ocular involvement may lead to blindness if untreated. May also have hypopion and non-isocyclic pupils due to scarring of the uvea. Then you can have also cardiac manifestations, so heart block and sudden death. Heart failure from cardiomyopathy rarely occurs. Approximately 25% of patients may have non-caseating granulomas at biopsy, but fewer than 5% have clinical cardiac disease. Hypercalcemia and renal disease. Hypercalciuria occurs in 10% in 40% of cases. Hypercalcemia in 11%, renal calculi in 10%, intrarenal calcium deposition may be so severe that it might cause renal failure. You can have also sarcoidal macrophages, so you can have this renal failure even. Sarcoidal macrophages possess 25-OH vitamin D1 alpha hydroxylase. This can lead actually to this hypercalcemia. Renal failure due to granulomatous nephritis rarely occurs. 24-hour urinary excretion of calcium should be measured in all patients with sarcoidosis. You can have bone and joint involvement, MRI and PET. Bony lesions scattered throughout the skeleton are often detected in patients with sarcoidosis. You can make a differential diagnosis with metastatic bone lesions. Although skeletal lesions may cause pain, most are symptomatic. Chronic arthralgia is more common than frank arthritis. Diagnosis. Clinical finding. It's consistent clinical presentation allowing to make a diagnosis. We have radiologic findings, hilar lymphadenopathy and granulomata, supported by histologic evidence in one or more organs of non-caseating epithelial cell granulomas in the absence of organisms or particles. Must always demonstrate the presence of granulomas and that they are normal organisms inside them. Lab tests are routine lab evaluation often is unrevealing. Hypercalcemia or hypercalciuria may occur. An elevated transaminase level suggests hepatic involvement. Angiotensin converting enzyme levels may be elevated. NCGs secrete ACE. Non-caseating granulomas secrete ACE, which may function as a cytokine. Serum ACE levels are elevated in 60% of patients at the time of diagnosis. Levels may be increased in fluid from bronchoalveolar lavage or in CSF. Sensitivity and specificity as a diagnostic test is limited, 60 and 70% respectively. There is no clear prognostic value. Serum ACE levels may decline in response to therapy. Decisions on treatment diagnosis should not be based on the ACE level alone. Imaging studies are chest radiograph is central to evaluation. Routine chest CT can add little. A high resolution CT scan of the chest may be helpful. At biopsy, from the involved organ that is most easily assessed, so the skin, peripheral lymph nodes, lacrimal glands, or conjunctiva. Diagnosis requires pulmonary tissue transbronchial biopsy by means of bronchoscopy as a diagnostic yield of at least 85% when multiple lung segments are sampled. The central histologic finding is the presence of non-caseating granulomas with special stains. A diagnosis of sarcoidosis is reasonably certain without biopsy in patients who present with Löfgren syndrome. Differential diagnosis is done by hilar infiltrates, tuberculosis, lymphoma, eosinophilic granuloma, fungal infection, lung cancer. Non-caseating granuloma on biopsy, so borreliosis, cat scratch disease, fungal infection, hypersensitivity pneumonitis, leprosis, primary biliary cirrhosis, tuberculosis. Prognosis. Generally, it's good. depends largely on the involvement. Clearly, if you have extrapulmonary involvement and pulmonary disease, the prognosis is worse. Markers of a poor prognosis include advanced chest X-ray stage, extrapulmonary disease, predominantly cardiac and neurologic, evidence of pulmonary hypertension. Multiple studies have demonstrated that the most important marker for prognosis is the initial chest X-ray stage. So, the markers of poor prognosis are advanced chest X-ray stage, extrapulmonary disease, predominantly, predominantly cardiac and neurologic, and evidence of pulmonary hypertension. The chest X-ray is the most important marker. Remission: 2–3% of patients with sarcoidosis generally have a remission within a decade after diagnosis with few or no consequences. Remission occurs for more than half of patients within 3 years. Unfortunately, after 1 or 3 more years of remission, a recurrence after 1 or more years of remission is uncommon, affecting less than 5% of patients. But recurrent disease may develop at any stage, at any age, and in any organ. Less than 5% of patients die from sarcoidosis. Death is usually the result of pulmonary fibrosis with respiratory failure or of cardiac or neurologic involvement. Raynaud's phenomenon. 35% of general population has Raynaud's phenomenon. In 80% of cases, we have an increased physiological pathological response to cold, so primary Raynaud's. In other cases, it may be the manifestation of an underlying condition, secondary Raynaud's. Primary Raynaud's phenomenon, we have early onset, mean age at 14 years. 70% of cases, it's less than 35 years. It's symmetric, less severe, absence of trophic lesions in the fingers, absence of other symptoms, familiarity in 25% of cases. So primary Raynaud's, early onset, symmetric, less severe, absence of trophic lesions in the fingers, absence of other symptoms, and familiarity is present in 25% of cases, so we have some genetic factors. In secondary Raynaud's phenomenon, the age studies after 30 years. The gravity, we have its presence can be the presence of ischemic lesions. You can have possible asymmetry, presence of other pathological symptoms, alteration in the inflammatory indexes. How do you study Raynaud's with capillaroscopy? There are 2 places where you can see the microcirculation. Most proximal part of the nail. Vessels, in fact, go tangentially rather than perpendicularly, and the mucosa. Typically, you put some oil over the nail and then you place the lens of the video capillaroscope in order to visualize the morphology of the microcirculation. Video capillaroscopy is quite sensitive, so if the patient experienced a recent stroke or trauma to the nail, this may alter the result and show pathological findings. Patients undergoing video capillaroscopy should also not have any nail polish and be in warm environment for several minutes to an hour before the exam is performed. On the right of the image of the top, on the right, the top image shows a normal pattern capillaroscopy. The bottom image shows a scleroderma pattern where you see megacapillaries, microaneurysms, and ruptured capillaries. Systemic vasculitis and connective tissue diseases associated with Raynaud's phenomenon. You have scleroderma group, so diffuse systemic sclerosis, limited systemic sclerosis, and the CREST syndrome. Undifferentiated connective tissue disease, mixed connective tissue disease, systemic lupus erythematosus, Sjogren's syndrome, polymyositis dermatomyositis, rheumatoid arthritis, and cryoglobulinemia and other vasculitides. There are 4 major phases in order to say that a patient has Raynaud's phenomenon. We have a white phase, which is the ischemic phase. We have a blue phase, which is the cyanotic phase. We have the red phase, where circulation starts again, and we have the normal phase. And the color goes back to normal. A proper Raynaud's phenomenon should have all 4 phases, so white, blue, red, and normal. Some patients will tell you that they have some fingertips, they have blue fingertips when it's cold um, outside, but then go back to normal. This condition is called acrocyanosis. It's a kind of paraphysiological response to cold with a significant constriction, but it's absolutely normal and not associated to any disease. These patients will often tell you that they have Raynaud's. In this case, always inquire about the 4 phases, especially the white phase. It is extremely specific for Raynaud's. Another important thing about Raynaud's is that there is a clear demarcation of the ischemic part. Only 2% of patients who have criteria for primary Raynaud's phenomenon and are and rheumatoid factor negative will develop a connective tissue disease during follow-up. But 15 to 20% of patients with primary Raynaud's phenomenon without a definitive diagnosis of connective tissue disease with a positive AN or capillaroscopy will develop a connective tissue disease in the following 2 years. So the take-home message is ask for ANA testing and capillaroscopy. If it turns out to be positive, you may need to perform an extensive follow-up in those patients or refer them to a rheumatologist. Probability is much higher if there are present anti-topoisomerase 1, SCL70, and anti-centromere antibodies. This is because these antibodies are very specific and are frequently found in patients with particular diseases like scleroderma. So, which are the other causes of Raynaud's phenomenon? We can divide them with vascular abnormalities and normal vessels. In case of vascular abnormalities, we can have abnormalities in the large and medium arteries, so thoracic outlet syndrome, brachiocephalic trunk disease, with atherosclerosis, giant cell arteritis, Takayasu, or in the small arterioles. In the small arterioles, we can have systemic sclerosis, SLE, dermatomyositis, polymyositis, primary biliary cirrhosis, thromboangiitis obliterans, and chemotherapy with bleomycin. The blood, when we have normal vessels, we can have blood abnormalities or vasomotor abnormalities. Blood abnormalities are cryoglobulins, cryofibrinogeninemia, paraproteinemia, cryoagglutinins, polycythemias. Vasomotor abnormalities can be primary drugs, so beta blockers, ergo derivatives, pheochromocytoma carcinoma hypothyroidism, or Prince metal angina.